So this interpretation of biomarkers, clinical feasibility, that is the most popular is HbA1c, hemoglobin A1c, very commonly applied biomarker to detect pre-diabetes and diabetes. Its formation occurs by adherence of glucose to amino terminal group of beta subunit of hemoglobin. It is a reflector of prolonged hyperglycemia, preferably than pinpoint blood glucose level at one spot. Now ADA fixes HbA1c, that is about 6.5, that is 48 millimoles per mole, and that of pre-diabetes is 5.7 to 6.4, that is 39 to 46 millimoles per mole. The increased HbA1c level is associated with a high morbidity and mortality. The Norfolk prospective cohort study shows raised HbA1c levels are correlated well with high cardiovascular disease, malignancy, and all-cause mortality. What are the studies and diabetic complications? The UKPDS, DCCT, EDIC studies have clearly shown diabetes complications are directly related with an average of HbA1c about more than equal or more than 6.5%, that is 48 millimoles per mole, associated with the retinopathy. Thus, in addition, HbA1c is more correlated with the microvascular complications like retinopathy than with fasting plasma glucose. The advantages of HbA1c, many gains comparatively with the FPG and OGT, oral glucose tolerance test, that is no fasting is needed, desired steadiness, less disturbances, while patients at stressful situations and ailments. So another added advantage of HbA1c, that is it mirrors prolonged exposure to glucose and thus helps to advise lifestyle modifications. So the vital point to be noted is oral glucose tolerance test and fasting plasma glucose are better indicators of insulin resistance and secretory state than HbA1c, which is anticipated as the reaction to high level of glucose, thus casting the person's the physiological response and secretory state of insulin and action. So HbA1c versus OGTT. So HbA1c has moderate sensitivity of diagnosis of diabetes. In a way, HbA1c and OGTT values are not congruent, as sometime when we position the patients in pre-diabetes as per OGTT, but by HbA1c cutoff points, they are in normoglycemic states. So there are so many, that is the Hampere study, that is all those program. We are not sure of HbA1c is a sensitive marker as by ADA guidelines. We may rather fail to note persons with the pre-diabetes HbA1c being less than 5.5%, that's about 37 millimoles per mole. The National Health and Nutritional, that is the examination, survey, and screening of impaired glucose tolerance study revealed about 60 to 70% of individuals have had normal glucose tolerance, that is normal glucose tolerance at HbA1c levels less than 5.7, that is 38.9 millimoles per mole. So HbA1c pre-diabetes, in fact, HbA1c level for pre-diabetes is not considerate of race, BMI, and age, which are affecting HbA1c values. So as it varies ethnicity, for example, HbA1c being high in Asians, standard allocation may rather misdiagnose persons of particular ethnicity as pre-diabetes. What are the variations? It is not a sure method to ascertain disseminating glucose levels. It is correlated to lifespan of red blood cells being 90 to 120 days. So any variation in production range or circulating life period of RBCs will affect HbA1c. Thus, reduced production of RBC results in more percentage of old cells. On the contrary, more rapid turnover decreases average time. During this period, the RBCs are exposed to hyperglycemia. So many conditions lead to either overestimation or rather underestimation of HbA1c. What are the variations? Iron deficiency anemia, folic acid, B12 deficiency, asplenia, severe hypertriglyceridemia is and uremia will falsely elevate HbA1c. On the contrary, hemolytic anemia, blood loss, end stage renal disease, splenomegaly will lead falsely low HbA1c. Moreover, hemoglobin variants such as that is HbS, HbC, HbD, and HbE may lead to overassessment or underestimate of HbA1c based on the usage of modality. Thus, HbA1c alone may not be an apt marker to diagnose pre-diabetes, so we need other biomarkers to arrive at more proper diagnosis. So everything has got its own limitations. What is fructosamine FA? It is a biomarker of screening diabetes and helpful to diagnose pre-diabetes. It is a ketamine generated by total serum proteins, especially albumin. It increases at glucose states. It is a reflector of average span of blood glucose levels for the past 1 to 4 weeks. So fructosamine is a useful biomarker of short interval glycemic variations and control of glucose. And fructosamine is valuable in situations affecting hemoglobin dependence and is a marker of moderate sensitivity and high specificity. It is rather convenient as it does not require fasting and is cost effective. But fructosamine has its own boundaries due to its individual variations, rapid turnover of albumin in nephrotic syndrome and liver disease. It will result false low values. So fructosamine, some studies are not favoring fructosamine as a reliable marker in pre-diabetes. But many studies parallel with hyperglycemia and HbA1 values in type 1 and type 2 diabetes mellitus. Fructosamine also marks the menace of developing microvascular complications. It is an alternate biomarker of HbA1c when clinical states affect the values, but it has limited data. Then what is glycated albumin? It is also a good biomarker when compared to HbA1c, especially in situations affecting HbA1c, for example, renal failure, hemolytic anemia, and patients getting blood transfusions. And the fructosamine includes all glycated proteins, including glycated albumin. So it oscillates in states like liver disease. Glycated albumin reflects the ratio of glycated albumin to total albumin. So glycated albumin is preferential, particularly in situations leading to loss of protein, for example, nephrotic syndrome, liver disease, thyroid disease. Moreover, we are not certain if fructosamine has to be corrected for total protein concentration, except a study revealing a betterment of fructosamine with HbA1c, where fructosamine is rectified for albumin. So glycated albumin, Asians have diabetes, serum glycated albumin levels about 15%. It has moderate sensitivity and specificity to diagnose pre-diabetes and diabetes. Anyhow, we can improve sensitivity of glycated albumin if we combine FPG less than 100 milligram percent minus 5.56 millimoles per liter with glycated hemoglobin less than 15% to rule out diabetes and FPG more than 126 per deciliter, that is 7 millimoles per liter, with glycated hemoglobin more than 17% to diagnose diabetes. So the disadvantage is when there are changes in albumin turnover and false low values in obesity. It is a marker of pre-diabetes and diabetes. Then oral glucose tolerance, we all very well know, 2-hour plasma glucose, 1 hour is also done to pick up more cases aptly. Sensitivity and specificity good, 0.93%, 0.81% respectively, sensitivity and specificity. It is well tolerated with insulin resistance, secretion. OGTT is a better risk assessor when compared to HbA1c, fasting plasma glucose, which may not. The limitations of OGTT is it is variable, invasive, time consuming. Moreover, it needs fasting and reveals day-to-day variability during stores and ailments. So it marks pre-diabetes and diabetes. Another marker is 1,5-anhydroglucitol. It is a dietary monosaccharide. It has inverse relationship to plasma glucose. It is due to proximal glucose tubules have high affinity for glucose than 1,5-anhydroglucitol. High glucose prevents 1,5-anhydroglucitol reabsorption, leading to increased its urinary excretion. It is a biomarker of fast 2 weeks rather 10 to 14 days. It is a stable, reliable, and less costly test comparatively to other tests. If less than 17 microgram per ml for diabetes defined by an average of HbA1c more than 6%, the sensitivity is about 0.96% and specificity is about 0.86%. It is rather helpful to find postprandial fluctuations and patients at risk of microvascular, especially retinopathy and macrovascular complications. But it is not clear whether it overtakes HbA1c. It also changes with the diet, sex, race, renal hemodynamics, and patients on sodium glucose transporters 2 inhibitors. It is not a reliable marker of prediabetes. Then what is the role of adiponectin? It's a good hormone secreted by adipocytes, the adipose tissues. It possesses insulin sensitizing, anti-inflammatory, and anti-atherogenic qualities. So many hormones are being secreted by adipocytes. That's why it is called endocrine organ. Not only this, adiponectin, leptin, resistin, bisphatin, interleukin alpha, so many hormones. This adiponectin is an autonomous marker of diabetes. Increased insulin resistance and obesity are related to low levels of adiponectin, whereas lifestyle of modifications are correlated with high levels as revealed, that is by diabetes prevention trials. Adiponectin levels are also incorporated with the risk of prediabetes independent of sex and ethnicity. It bears direct association with the insulin sensitivity and indirect association with the insulin resistance. Then what is the role of phetuin A? It is a hepatic secretory glycoprotein indicating increased risk of, that is the proneness to type 2 diabetes mellitus and related complications. What is to note is the EPIC post-DAM prospective cohort study revealed that is phetuin A is an independent marker of type 2 diabetes mellitus after restraining, that is body mass index and waist circumference, unlike adiponectin. It is a marker of lipid-induced insulin resistance by toll-like receptor 4, that is TLR4, an inflammatory signaling pathway leading to production of inflammatory cytokines. But many studies are rather disputing its association with cardiovascular disease, except a US study. Then what are the metabolites and microRNA? That is amino acids, branched chain amino acids, and aromatic amino acids have positive relation, while glycine and glutamic acid have an inverse relationship. Thus, changes in circulating amino acids indicate insulin resistance and type 2 diabetes mellitus. Then another biomarker is alpha hydroxybutyrate, that is alpha HB. It is an organic acid byproduct produced during the synthesis of alpha, that is ketobutyrate, butyrate, alpha KB, a product of amino acid catabolism, that is threonine and methionine, and glutathione anabolism, that is cysteine formation pathway in hepatic tissue. It is a biomarker of insulin resistance and prediabetes. Then this lineal glycero, that is choline LGPC. That is LGPC is a metabolite produced by the enzyme phospholipase A2 in liver by lecithin cholesterol acyl transferase in circulation. This amid inflammation, phospholipase A2 activity is increased. Thus, linyl glycerophosphocholine LGPC is a negative prognosticator of type 2 diabetes mellitus. So another is lipoprotein A triglycerides. So LPA is a lipoprotein subclass related to atherogenesis. It bears inverse relationship association with proneness to prediabetes and type 2 diabetes mellitus. Then the role of triglycerides. Triglycerides are esters obtained from glycerol and 3 fatty acids. So hypertriglyceridemia leads to lipotoxicity, which in turn causes beta cell dysfunction, reduced insulin secretion, apoptosis by ceramics, and nitric acid production, especially in prediabetes. Then HDL and ceramide. HDL is a major lipoprotein. It activates insulin secretion. Low HDL-C results in development of prediabetes to diabetes. So there is an increased proportion of small HDL3 over HDL-C and decreased proportion of HDL lipoprotein, that is LA2, in prediabetes. So what is ceramide? It is a lipid molecule positively correlated with pre-diabetes and type 2 diabetes mellitus. Then what is the role of ferritin and transferrin? Now it is gaining momentum in COVID-19. Ferritin is nothing but an intracellular protein. It is a storage form of iron. It releases iron. Raised levels are well correlated with the high risk of pre-diabetes and diabetes. Iron has qualities of imparting insulin resistance, a wise, highly active radical production, damage to DNA and cell membrane integrity. Then beta cell oxidative stress and catalytic ion. So the beta cell oxidative stress results decreased insulin secretory capability and interference with the glucose uptake by skeletal muscle and fat cells. We all know the insulin sensitive tissues is skeletal muscle, adipocyte, and liver. In addition, catalytic ion activities production, reactive oxidative species, that is ROS, hepatic dysfunction, and beta cell apoptosis, all of which lead to insulin resistance. What is the M-mannose binding lectin serine peptidase? Then this is called the thrombospondin I and glycophosphatidinose and specific phospholipase D1. So this MBL-associated serine proteases are important enzymes for so-called innate immune response and activation of lectin pathways of the complement system. Then the THBS1, it is a multi-protein complexes formation. So cellular phenotype, for example, it stimulates, inhibits migration of vascular smooth muscles or endothelial cells respectively. So this THBS1 is related to prevalence of prediabetes, increased insulin resistance, 2-over glucose, adipose inflammation, and metabolic dysregulation of obese individuals and type 2 diabetes mellitus. Then this GPLD1 and acylcarnitine. It acts through insulin mimetic signaling pathways, being postulated by the role of GPLD1 through the exact mechanism is not known. So the type 2 diabetes mellitus and pre-diabetes less reliable. Then what is the role of acylcarnitine? It interacts with the nuclear factor kappa B, which promotes inflammation and insulin resistance and is associated with the pre-diabetes. The precise role of acylcarnitine play has not yet been elucidated. Then microRNA involved in cell growth, differentiation, proliferation, death-specific microRNA. This microRNA 192 regulates the tumor protein P53. And 193B is also involved in the so-called BAT, brown adipocyte differentiation and inflammatory reduction. It is thought to directly inhibit uncoupling protein 2 gene expression, leading to increased oxygen consumption and reduced adenosine triphosphate generation, thus promoting insulin synthesis. Others thought to play a role in beta cell function. So many microRNAs are related to prediabetes, that is 192, 193B, are correlated with impaired fasting, IGT, hypertriglyceridemia, high fatty liver index. The other microRNA that is take part in insulin production, secretion, and regulation. So the C-reactive protein, again, it is a marker of inflammation. Why it is called a C-reactive protein? It is being secreted by liver. It reacts with the C polysaccharide of mycobacteria, that is pneumococcus. So it is called C-reactive protein. It is also gaining momentum now in our COVID pandemic era. Another is IL-6, C-reactive protein derived from interleukin 6 dependent hepatic biosynthesis. It's a prime marker of acute phase reaction. It is related with the type 2 diabetes insulin resistance. It is also related to pre-diabetes. In fact, CRP is found increase in individuals with pre-diabetes and insulin resistance than with the diabetes but insulin sensitive. Then the role of IL-6, immune regulatory property, and is well correlated with the glucose homeostasis and metabolism by action on pancreatic beta cells, adipocytes, hepatocytes, and skeletal muscles. It is related to type 2 diabetes mellitus and insulin resistance. So the inflammatory biomarkers, C-reactive protein, interleukin 6, white blood corpuscles, fibrinogen, PAL, plasminogen activating, interleukin 18, IL, IRA. So WBCs again count is a marker of immunity and inflammation. Again, in COVID, there is lymphopenia. The NLR, that is neutrophil lymphocyte ratio, is an indicator of subclinical inflammation and microvascular and macrovascular complications in diabetes. WBC count portends worsening of insulin action, secretory function, type 2 diabetes mellitus, coronary heart disease, high 1 hour post-load glucose levels. Fibrinogen actions affect blood viscosity, platelet aggregation, fibrin formation. It is rather associated with the pre-diabetes, weakly related to diabetes, high 1 hour post-glucose load atherosclerosis. Another important marker is myonectin, will come shortly. This is called plasminogen activated inhibitor. This is a marker of reduced fibrinolysis. The reduced activity results in, that is, defective coagulation. That is, this is a IRA study shown the PAL, plasminogen activator inhibitor level change is an independent marker of incident diabetes. IL-6 interleukin-6 cytokines exhibit immunoregulatory actions and are involved in glucose homeostasis and metabolism through action on pancreatic beta cells, adipocytes, hepatocytes, and skeletal muscle. So IL-18, IL-1RA, they are all very important in hyperglycemia, that is associated with high risk of type 2 diabetes mellitus, also related with progression pre-diabetes to diabetes. IL-1RA, anti-inflammatory marker, elevated IL-1 pathway induced by glucose and free fatty acids and overfeeding. It is also associated with insulin sensitivity, temporary beta cell function increase, and is also elevated in pre-diabetes and diabetes. This is what I told the myonectin. It predicts the development of type 2 diabetes. Myonectin has been identified as a myokine, expressed predominantly in skeletal muscle. However, its clinical implications are largely unknown. 104 newly diagnosed type 2 diabetes, 109 impaired glucose tolerance, and 128 healthy individuals were recruited for this study. Conclusions, these data suggest that myonectin may be a useful marker in predicting the development of pre-diabetes and diabetes. It's a very recent, 2 years old article. So patient peer reviews as per the data, that is the diabetes, that is the Center for Disease Control and Prevention, about 90% of pre-diabetes are underdiagnosed. Thus, they don't get guidance on lifestyle modifications to prevent development of type 2 diabetes mellitus. HbA1c, glucose estimations are being utilized for screening for a long time. Each one has its drawbacks. It is evident, as we have already described, HbA1c is not a sensitive marker of acute and intermittent hyperglycemia. It may be influenced rather by severe diseases and ethnicity. So other biomarkers add value. OGTT informs us the risk of development of type 2 diabetes mellitus, whereas HbA1c and FPG don't. It is associated with the noted variations that requires fasting, inverse, and time consuming, but OGTT has its value, especially post-load levels of 30 minutes, 60 minutes will assess development of type 2 diabetes better than fasting. In addition, the 2-hour post-load glucose or HbA1c makes us hassle-free. We need more studies to bring out biomarkers to identify diabetes as a single biomarker as its own boundaries. So combination of biomarkers is vital to identify individuals at high risk of prone for pre-diabetes and further development to diabetes. So the conclusion, this is the last slide, dysglycemia, classification, and aptly defining it when applied to non-stop pathophysiology may unintentionally underscore those individuals developing diabetes. Though beta cell dysfunction occur earlier to progression from rising glucose levels, even within the so-called normal range happens relatively late in the development of type 2 diabetes mellitus. So it is rather essential for the need of biomarkers of precise sensitivity, specificity to assess development to dysglycemic levels as early as possible at a point when beta cell function starts decompromising and a state which responds to lifestyle modifications. Adding biomarkers in a clinical state, it adds value for a better sensitivity and specificity of assessing pre-diabetes and diabetes. We need more studies and data to confirm its clinical application. Now the genetic studies are on the vogue as they may add further information. Thank you for the patient listening. We will soon meet at the CCDS Con, that is the 10th and 11th. Thank you very much. Over to Dr. Lohani and the moderator of the next speaker, Dr. A.N. Roy. Please, Dr. Lohani, please.
Thank you, Dr. RAJASEKAR. Good evening, everybody. On behalf of CCDSI, I once again welcome you all in this webinar. In this era of Corona pandemic, webinar has become a very important medium for continuing medical education. In this CME, we are going to discuss a very, very important topic, that is pregnancy and diabetes. As we all know, diabetes affect about 10% of total pregnancy world over. What is more important to note is that diabetes in pregnancy is different from the diabetes we see in clinical practice. Its etiopathogenesis is different, its diagnostic criteria is different, and its management is different. To discuss all these issues, we have with us none other than Dr. A.N. Roy as a speaker, who needs no introduction in any gathering of physicians in this state and this country. We all know he is the founder of CCDSI. He is the professor in the department and principal. So without wasting any time in formalities, I request Dr. A.N. Roy to proceed with his presentation. Sir, please.
Thank you, Dr. Lohani. Dear Dr. RAJASEKAR, President CCDSI, Dr. Khetan, incoming President of CCDSI, and other colleagues. My topic is diabetes in pregnancy. This is very important topic, as Dr. Lohani has introduced. Pregnancy with the diabetes carries bad prognosis. There is an increased morbidity and mortality in both mother and fetus. Therefore, early diagnosis and proper management is essential for better outcome. Diabetes in pregnancy, epidemiology. Pre-16 diabetes complicates 1% of pregnancy. And in US, it is more than 8 million women. 4% of all pregnancy, this is very important. 4% of all pregnancy are affected by diabetes. 88% due to GDM, 8% due to type 2 diabetes, and 4% due to type 1 diabetes. So, majority of diabetes in pregnancy is gestational diabetes, 88%. Diabetes in pregnancy, what are the types? Gestational diabetes is the most common, and it is of two types. Type 1A, where there is an abnormal oral glucose tolerance test, but normal glucose, blood glucose level during fasting and 1 to 2 hours after meal. Diet modification is sufficient to control glucose level. Type 2A2, this is very important. Abnormal OGT compounded by abnormal blood glucose level during fasting and after meal. Additional therapy with insulin and other medication are required. Pre-gestational diabetes mellitus. Type 1, that is autoimmune diabetes mellitus, that is, we all know. And type 2 is the classical lifestyle type 2 diabetes. We all know about this. So still, just to repeat, the commonest type of diabetes is gestational diabetes. And out of the two, this gestational diabetes, type 1 is not so common. It is a type 2, A2 is more common. And this is the pre-gestational diabetes, type 1 and type 2. We all know there's nothing much to say about this. Now coming back to gestational diabetes. Insulin resistance, glucose intolerance, insulin resistance, glucose intolerance first diagnosed during pregnancy. Prevalence 1 to 4% of all pregnancy indicate predisposition to later development of type 2 diabetes. Chances of recurrence in future in pregnancy 30 to 84%. GDM risk factors. This is very important. Who are the ladies who are going to have this more gestational diabetes? Maternal age more than 25 years, body mass index more than 25 kg per meter square, race and ethnicity, that is Latin Americans, Native Americans, and the Southeast Asian and Pacific, and the most important is Southeast Asian. And if there is a history, personal or family history of diabetes or history of macrosomia in previous baby. So these are the ladies who are more prone to develop gestational diabetes. How to do GDM screening? DIPSI, this is very important. DIPSI has given the guideline. DIPSI recommends one stage procedure. A screening for DDM is recommended between 24 and 28 weeks of gestation. GDM is diagnosed when the plasma glucose 2 hours after 75 gram of oral glucose load is in fasting stage is more than 140 milligram. This is very important. We follow the DIPSI guideline. So any pregnant lady after 75 gram oral glucose in fasting stage and the blood glucose is more than 140 milligram, which we diagnose that this patient is having GDM, most likely GDM. Now, how to confirm a diagnosis? Confirmation is all we know. If the person, if already it is there, if the fasting blood glucose is more than 126 or PP glucose is 200, so there is no problem here. But in majority of cases, you may require 100 gram 3 hours glucose tolerance test, and GTT with 2 or more abnormal values will suggest gestational diabetes. And the fasting, there are two Carpenter and Custom and National Diabetes and Data Group. There are two groups. Fasting for the Carpenter group is 95, 1 hour 180, 2 hours 155, and 3 hours 140. While National group, it is slightly higher, 105 fasting, 1 hour 190, 2 hours 165, 3 hours 145. So any two abnormal level, this is very much with the 2 or more abnormal value, we can diagnose gestational diabetes. So confirmation either is the fasting is more than 126 or PP 200, we all know, or abnormal glucose tolerance for any two readings. Now physiological change in pregnancy. This is just repeat. We all know about this. Sodium and water retention is the most important. Reduced systemic blood pressure mean 105 to 60 millimeters in second trimester. Increased cardiac output that rises 30 to 50%. Increased blood volume, total body water increases 40%. Reduced systemic vascular resistance, vasodilatation plus high flow, low resistance circuit of the uteroplacental circulation, and increased maternal heart rate that up to 15 to 20 per minute. So these changes are occurring in pregnancy. What are the metabolic changes which occurs? Calorie requirement for a pregnant woman is 300 kilocalorie higher than the non-pregnant woman. Patient needs placental hormone of affect glucose and lipid metabolism to ensure that fetus has ample supply of nutrients. So there is an increase in demand in calorie, that is about 300 calories per. Metabolic change in pregnancy, lipid metabolism, increased lipolysis. The lipolysis is important, preferentially used for fat for fuel in order to preserve glucose and protein. Glucose metabolism, and in glucose metabolism, there is a decreased insulin sensitivity and increased insulin resistance. What are the causes of increased insulin resistance? Due to hormones secreted by the placenta that are diabetogenic, and these are growth hormone, human placental lactogen, progesterone, corticotrophin relief factor, and transient maternal hyperglycemia occurs after the meal because of increased insulin resistance. Metabolic change in the pregnancy continue. Lipid metabolism, increased serum triglyceride 300%, and cholesterol rises of 50%. This is spares glucose for fetus since lipids do not cross the placenta. Provides building block for increased steroid hormone synthesis. Diabetes in pregnancy, clinical implication, obstetric complications. What are the obstetric complications? Increased incidence of miscarriage, congenital malformation. Incidence is 4 time higher than in normal than in general population. Most remaining cause of fetal death is congenital malformation. So it is a 4 times normal than the normal population. It's associated with hypertensive disorder of pregnancy, gestational hypertension, and preeclampsia. So these are the implications. And this is the fetal macrosomia, and this is shoulder dystocia. This shows. Diabetes in pregnancy, clinical implication, obstetric complication, preterm delivery, intrauterine fetal demise, traumatic delivery, e.g. shoulder dystocia, operative vaginal delivery, vacuum assisted, and forced vacuum. So this you prefer is operative vaginal delivery, assisted vaginal delivery. Diabetes in pregnancy, clinical implication. Again, I'm just repeating, fetal macrosomia, disproportionate amount of adipose tissue is adipose tissue concentrated around shoulder and chest. Respiratory distress syndrome, neonatal metabolic abnormality, that is hypoglycemia, hyperbilirubinemia, and jaundice, organomegaly, and polycythemia. Perinatal mortality and long-term predisposition to childhood obesity and metabolic syndrome. Management, glycemic control. Significant benefit of insulin therapy. Prior to insulin use, perinatal mortality was 65%. After introduction of insulin therapy, perinatal mortality declined to 5%. So insulin is the seat anchor of the treatment. And what is the goal of the management? Glycosylated hemoglobin should be less than 6%. Less than 6%. And level between 5 and 6 are associated with fetal malformation rate compared to those observed in the normal pregnancy. So HbA1c should be less than 6%. Goal of normal or near normal glycosylated hemoglobin level for at least 3 months prior to conception. If the ladies come to you for that she wants to have pregnancy, we should encourage that her HbA1c should be below 6%. At least 3 months prior to the conception. Management, that is we all know, lifestyle nutritional therapy, home self glucose monitoring, medical therapy if glycemic control are not achieved with the diet and exercise, subcutaneous insulin, and oral hypoglycemic agents. Nutrition, calorie requirement, normal body weight 30 to 30 kilocalorie per kg per day. Distributed in 10 to 20% at breakfast, 20 to 30% at lunch, and 30 to 40% at dinner. Up to 30% of snacks to avoid hypoglycemia. Calorie composition, 40 to 50% from complex high carbohydrate, 20% from protein, and 30 to 40% from primary unsaturated fat. Management, oral hypoglycemic agent. Though they are advocated, but as I told you earlier, insulin is a seat anchor of treatment. But some patients are very reluctant to take insulin in spite of great participation. So we can, for them, we can advise metformin, which is insulin sensitizer, 5 milligram to 1 gram daily, or glucosamide, insulin secretagogue. But we should always encourage insulin. Manage the subsequent insulin therapy. I told you insulin requirement increases rapidly, especially from 28 to 38 weeks of gestation. First trimester, the dose is 0.7 to 0.8 unit per kg per day. Second trimester, it increased to 0.8 to 1, and third trimester 0.9 to 1.2 kg per day. Management summary: pre-gestational diabetes, optimized glycemic control, frequent insulin dose adjustment. Type 1 often have insulin pump, type 2 subcutaneous insulin. Fetal monitoring started at 28 to 38 weeks, depending on glycemic control. Ultrasound to assess growth at 36 weeks. Delivery at 38 to 39 weeks. Management summary: begin with diet, walk with each meal. In borderline, mild elevation, consider metformin, start 5 mg daily. If elevation start out moderate to severe, metformin fails, proceed to subcutaneous insulin. So, in early stages, if it is mild, you can start with metformin, but if the patient has moderate to severe degree, you go for insulin. And NPH or Humulong, these are, you can use other insulin also, so insulin is a treatment of choice. What is management glycemic goal? Blood glucose level goal during pregnancy. This is very important. Fasting should be below 95 milligram per deciliter. On hour should be between 130 to 140 milligram, and 2 hour postprandial less than 120, and any time it is less than 120. So this is very important. Fasting less than 95, and any time after the fasting it should be below 120. Normal glucose level should not go below 60 milligram per deciliter, and normal postprandial glucose measurements are more predictive adverse outcome than preprandial measurement. Management intrapartum. I'm just leaving. Management of postpartum, this is very important. For all Indian patients, perform 75 gram 2 hour OGTT at 6 weeks postpartum visit to rule out pre-gestational diabetes. Most common recommendation is for primary care physician to repeat 2 hour OGTT every 3 years, just to rule out the patient has developed with type 2 diabetes. Take home message: diabetic female planning for pregnancy should be advised to have a good control of blood sugar to avoid fetal complication. And as it was told, for at least 3 months prior to the conception, her HbA1c should be below 6. All pregnant females should be screened for gestational diabetes at 24 weeks of pregnancy if they have following features. That is age, about 25 years, BMI, more than 25 kg per meter square, family history of diabetes, race, South and East Asian, history of macrosomia in pregnancy. Take home message: strict control of blood sugar target, fasting blood sugar 95, PP blood sugar more than 120, and HbA1c below 6.5. I think it is below 6. It should be below 6. Insulin is the treatment of choice. Thank you.
Thank you.
Thank you.
Thank you. Thank you, Dr. Roy, for the nice presentation. As Dr. Mrityunjay has correctly pointed out, patients who are on moderate albuminuria are prone for diabetes. Yes, we do agree. There is another question Dr. Roy can highlight. Many physicians are rather hesitant to put the patients on metformin when the patients are on GDM. Please highlight on it.
Yeah, as I told you earlier, because oral hypoglycemics are not advised, not the drug of choice for the management of gestational diabetes or diabetes in pregnancy. Insulin is a treatment of choice. But here in our part, since the patients are very much reluctant to take insulin, I don't know why, in spite of great persuasion, they are resistant to take. And in those cases only, we can consider oral hypoglycemic. Otherwise, all cases of patient with diabetes and pregnancy should be given insulin. This is my comment. It should be advised to our patient.
Thank you, Dr. Roy. I want to add one more point. See, patients who are on PCOD becoming pregnant, no doubt we can continue this metformin. So far, we have had no problem. It is also recommended. And even alpha glucosidase inhibitors, this is not systemically absorbed. It is also rather a safer drug. And insulin, as Dr. Roy has correctly pointed out, that should be the drug of choice. It is rather easy to control gestational diabetes, rather diabetes complicating pregnancy. In diabetes complicating pregnancy, always insulin is the choice. Thank you very much. Over to Dr. Mrityunjay.
So, thank you very much, sir.
Dr. Lohani. Dr. Lohani, please.
Dr. Lohani, okay. Answer.
I wanted to invite opinion of Dr. Rai and Dr. RAJASEKAR on one thing: which insulin is safe and which insulin is contraindicated in pregnancy. I think it should be discussed. Which insulin is safe and which insulin is contraindicated? Because we have a lot of insulin in the market, which should be advised to pregnant ladies.
Dr. Rai?
Yes. Dr. Lohani, I think nowadays they say that NPH insulin should not be given. It is human insulin or long-acting or short-acting combination. Which combination of 30-70 should be the choice. But in acute emergency, you can go for Actapid, that is soluble insulin, human insulin. So that is the choice. It is not NPH insulin.
Yes, I
Can
do
we
agree.
can we use long acting insulin like glargine in these
No.
GDM patients? No.
Normally, it is not recommended. It is not
Glargine
recommended.
is wait, glargine is not.
Yeah,
They don't. They don't. They are not.
Doctor,
Yeah.
can I
Yes,
speak,
Dr.
sir?
Panda, you want to say something?
Sir, with permission, sir. Yes.
Yeah.
So the question Dr. Mrutyunjay has asked has got two things. One thing that it is usually we have been using the long acting is the datamir. Is datamir here in India also. But some people are also using glargine. That is your number one. Number two, the short acting, ultra short acting like Lispro and Aspart. They are
Aspart.
being also used also.
Yes,
And
they can be used.
yes,
Yes.
sir, they should be used and they can be used.
See,
And it is theoretical, but sometimes clinically, looking to the persons, I mean, the type of patient we get from the rural areas, they can afford this thing. So some sort of things, cerebral insulin also can be given, human insulin can be given also. So these are the priorities. But
I-
these questions are asked.
I think
Sir, I asked one question that was to Dr. Anand in Jaipur. He was talking on this. We asked that, are you giving datamir to everybody? He says, yes, sometimes, but is it contraindicated? No, it is contraindicated. If it is given, suppose in absence of datamir, that can be also given. But this is no data, sir. No data is there.
I think Dr. Panda, we should educate insulin only.
Sir, that is okay. That is okay. Yes,
And,
sir, that is simple. Insulin,
Start
insulin.
and insulin Lispro can be used, as part can be used, but not others.
And
Glargine and datamir.
sir,
In my
regarding
opinion. What about RAJASEKAR?
regarding metformin, sir, it should not be used before 20 weeks.
Yeah.
And if it is PCOS, it should be continued.
Oh, yes.
No, sir, that's what. Not before 20 weeks, sir. Today I was in
RAJASEKAR.
sir, I was in RSSDI where Professor Anita Singh, she was telling, so this should not be given before 20 weeks, metformin. So that's what we agree also.
see, yeah.
Sir, thank you,
See,
sir.
if the patients on PCOD, they become pregnant, there is no, so
There is
far,
no-
no data proved. That's one
Sir,
point.
sir.
Regarding the rapid acting analogs, Aspart, Lispro, even glulysin, now they show green signal. And Detimer is proved beyond doubt can be used, long acting analog in pregnancy. But Glargine, they say a big query. So that we have to be careful. But as Dr. Roy says, always human insulin, we can close our eyes and give, so far no problem. That is short acting, as he said, the act rapid, and the intermediate acting, okay, well and good. Other insulins, we have to monitor and do it. Thank you very much.
Can I share my one point, sir? One point.
Please.
I have at least 10 to 12 patients I have given Glargine, sir, with consciousness. So they were fine. They have delivered. They are quite nice. I'm not saying this is what I have got my cases in
Okay.
Gaya.
Now they also nod their head.
Literature does not.
Sir,
Dr. Panda, in your sense, it is the glucose that matters, not the type of insulin. It's the control of the diabetes that matters, not
Sir,
the type of insulin.
thank you. Because the data is lacking, so we are apprehensive because of that. Thank
Exactly.
you, sir. Thank you very much. Thank you very much.
See, for example, the alpha glucose inhibitors, they don't recommend, but given for several patients or even many patients, so far we have had no, because there is no systemic absorption. So naturally, those who are not willing, we can, many patients will hesitate to take insulin, especially the diabetic patients. We use that alpha glucose test also. Thank you.
Sir, can I request in that, can I request one thing, sir? On this platform, I should request, let us have documentation, sir. Let us have documentation, whether on metformin or glargine, or for that matter, acarbose, or for that matter, anything. Documentation.
Sir, I have one point, sir. Sir, I am not able to understand why we cannot use alpha glucosidase inhibitor if serum creatinine is more than 2, because they have not got systemic absorption. But
Yeah, yeah.
it is written in our textbook that it should not be given above serum creatine 2. But I am not able to understand because
Yeah,
they have
yeah.
not got any systemic absorption.
Exactly. Thank you.
Thank you.
Yes, Dr. Mrityunjay, actually, this is as Dr. RAJASEKAR said, it can be given to patient with diabetes, heavy pregnancy safely. But as far as creatine concerned, you are right. It is not absorbed. So in what way it interferes with the renal function? Maybe it is checking out whatever it is. Maybe something there. It may have osmotic effect. Some water is there. So there may be other causes, not due to absorption. It's GIT causes. It may be that some water or electrolyte must be going with this. We do not know exactly. But it is not, since it is not absorbed systemically, it has got no systemic effect. So it is a local effect, and the local effect can have an effect on the kidney only when there is a loss of water or electrolyte. I don't know. I may be right, I may be wrong. But this is one way we can think.
Thank you. Thank you.
Now, Mrityunjay, now
Dr. Panda, you want to say unmute yourself. Please unmute yourself.
Sorry,
How you?
sir.
Yeah, please talk.
So using acarbose is fine, sir. But with a lady with pregnancy, they have got nauseating and GIT. Can it be used? I think this is a question for that one.
So everything has got its own limitations. How
Sir,
can
sir,
it be indicated? If they do well with that, if they are nauseating, flatulence, we should start.
Yes, sir. Thank you, sir. Thank you.
Thank you.
if they can tolerate, we can be used.
See, for example, gliflozin
Now,
is
Dr. Mrityunjay.
Okay. So thank you very much, sirs. At the outset, I would like to invite all of you to the 4th National CCDSI Conference, which will be held on 10th and 11th of October through webinar, and it will be from 3:30 p.m. to 9 p.m. So kindly join the National CCDSI Conference. And second thing, it is a very tough year for us due to COVID pandemic, but under the able leadership of Dr. RAJASEKAR sir, we have done uninterrupted academic programs under the CCDSI banner. So hats off to Dr. RAJASEKAR sir for doing this. And I must thank all the participants for active participation in these CMEs and these webinars. I would also like to thank all the both the speakers, Dr. RAJASEKAR sir and Dr. A.N. Rai sir, for nicely giving insight into the topic. So thank you very much to all of you on once again, and thank you to All Care Pharma for arranging this webinar. Thank you very much.
Thank you. Thank you. Soon meet on the National CCDSI. Thank you all.
Yes, thank
Good
you.
night,
Thank
sir.
you.
Good night. All the best, sir.